And so we know that ACOSOG Z11 demonstrated the safety of omission of axillary dissection in patients having upfront surgery who are clinically node negative with 1 to 2 positive sentinel nodes undergoing breast conserving surgery. Patients who had matted extracapsular extension or gross extracapsular extension were excluded from ACOSOG Z11, but patients who had microscopic extracapsular extension, which is just some growth of the disease outside of the lymph node capsule, were not analyzed in ACOSOG Z11. So at Memorial in 2010, we adopted Z11 as standard practice and developed a prospective database for all of our patients managed according to Z11. And so from 2010 to 2017, we had 811 patients undergoing breast conserving surgery who were clinically node negative managed according to Z11. There were 693 patients who had 1 to 2 positive nodes that were treated with sentinel node biopsy alone. And about 30% of them had microscopic extracapsular extension and were treated with sentinel node biopsy alone. Our primary endpoint was to look at nodal recurrence rates, and we demonstrated no isolated axillary failures in our cohort, whether there was extracapsular extension or not. And the rates of nodal recurrence were any nodal recurrence, which included association with either breast or distant recurrence as well, were not different between patients that had microscopic extracapsular extension or those that did not. We did notice that those that had microscopic extracapsular extension were more likely to be treated with nodal radiation therapy, about 40% of them were, but we still saw no difference in nodal recurrence in those patients. So the implications of this study are that, before we had demonstrated that patients with microscopic extracapsular extension in the sentinel node had a higher likelihood of having additional positive nodes, and particularly 4 or more positive nodes when they had greater than 2 millimeters of ECE. But in our study, we demonstrated low rates of nodal recurrence in patients with MECE. We call that instead of microscopic extracapsular extension. And so I think these patients can be safely treated without axillary lymph node dissection, and we demonstrated low rates of nodal recurrence, and therefore omission of axillary dissection in patients with microscopic extracapsular extension is safe. Hopefully people will begin to adopt this as we have at Memorial. You still have to use clinical judgment. I think if someone has other high-risk factors that make you more concerned and for a significant burden of disease, that you could move forward. But I think it's important to know that these patients do not require axillary lymph node dissection and have low rates of nodal recurrence, so hopefully it will be adopted soon.